person who embodies many characteristics that lead to prejudice and discrimination. A Black woman from South Africa who herself has experienced apartheid and continues to live under the crushing weight of racism and the legacy of colonization. I strive to fulfill my mandate as the UN Special Rapporteur on the right to health using an anti-coloniality, anti-racist approach to the right to health. I am convinced that intersectionality is the bridge to substantive equality and must be placed at the center of the operationalization of the right to health. My main proposal is made in an attempt to foster substantive equality in line with the peace, security, development, and human rights agenda of the United Nations. I prepared and presented to the United Nations General Assembly a report titled Racism and the Right to Health. The report highlighted the global health impact on racialized people, on the living legacy of past and ongoing forms of racism, apartheid, slavery, coloniality, and oppressive structures, including the global economic architecture, funding mechanisms, and national health systems. It also shed light on the impact of racism and discrimination, in particular on Black people, persons of African descent, migrants, and indigenous peoples and minorities, and the intersections of factors at play such as poverty and discrimination based on age, gender identity, expression, sexual orientation, disability, migration status, health status, and location in either rural or urban communities. It also highlighted residential segregation, which is a powerful predictor of health and well-being. Residents of communities which public health services are inaccessible or of poor quality face higher rates of preterm birth, cancer, tuberculosis, depression, and in comparison with predominantly white neighborhoods. Communities predominantly composed of people of African descent are more exposed to environmental toxins, air pollutants, carcinogens, which contributes to higher rates of pulmonary disease and lower birth weight. Racism and not race is a key social determinant of health, and racism is a driver of health inequalities. The report considers the impact of past and contemporary forms of racism and the right to health, and on the ability of individuals and communities to realize their rights to underlying determinants of health, such as potable water, food security, and racism still determines who has access to facilities, services, and goods. Racism is linked to poverty and is present in multiple localities. It leads to exceedingly high rates of police brutality, poor access to justice and recourse, mass incarceration, and a lack of access to housing, education, employment, and healthy food. Racism also leads to increased rates of mortality and morbidity, and it has been largely documented that it is related to adverse health outcomes and supported by available data. I also underlined the concept of epistemic injustice, whereby someone's knowledge or experience is not taken seriously or considered credible on the basis of an analysis of power and associated stereotypes, which has increasingly been applied in the context of healthcare. These injustices can be systemic and in particular where stereotypes and prejudice are deeply entrenched in the social world, as this is the case for racism and ableism and sexism and transphobia, to name a few. In the area of sexual and reproductive health, I remain concerned that even in the most comprehensive global data related to maternal mortality and morbidity, many vulnerable populations which are racialized are not represented and are therefore invisible. Even in countries with good overall progress indicators, the national level data often masks extreme disparities that exist between racialized population groups within these countries. These statistics illustrate the intersectionality between race and gender, as well as revealing the stark disparities along racial lines in outcomes for births, for example. I'm also concerned that many former colonized countries still carry the legacy of the European colonial regimes through their present-day restrictive laws, such as laws on abortion, laws that criminalize sex work, and in countries in which the criminal legal system disproportionately polices women and girls of African descent. And this population group suffers the most from increased surveillance and criminalization, restrictions to access to safe abortion, and therefore criminal sanctions for pregnancy outcomes and behavior during pregnancy, of course, continues to increase drastically. The health consequences of racism and discrimination are persistent and passed from one generation to the next through the body's biological memory of harmful experiences. The right to health cannot be realized in a racist world. Ending racism and related structural discrimination has become a central component of many global efforts to advance health and other human rights. We must engage meaningfully and with consequence those most affected, and towards a transformative and lasting change for racial justice, gender justice, and substantive equality. And as we mark the 75th anniversary of the Universal Declaration of Human Rights, and in the context of prevailing racism, we must interrogate what we have inherited and how we co-vision the future, an agenda for the sustainable peace, security, and development post-2030. There can only be one way forward, and it is a world without racism, and the right of everyone to the enjoyment of the highest attainable standard of physical and mental health depends on dismantling all the structures of systemic and structural oppression.